Hi, everyone. Thank you so much for joining us today. We are going to give folks just another about 30 seconds here to hop on in and join us, and then we're going to get started. Okay, so thank you everyone for joining us today for reducing the cost of benefits. I'm Kara Chucharelli from Foundation Software, and I am going to introduce your speakers today. So with us here, we have Jim Welsh, who is our Regional Sales Manager for Payroll4Construction through Foundation Software. He is going to be chatting with you guys here shortly. And then after that, you are going to hear for the main event from Adam Bonsky at ABC Insurance Trust to hear more about what you can do to reduce those costs of benefits. So without further ado, I'm going to hand it over to Jim.
Good morning, good afternoon, folks. As we know, we have people all over the country attending this. So first thing I like to do is just thank everybody for giving us some time here to talk to them today. As Kara had mentioned, I'm Jim Welsh with Payroll4Construction and kind of the Foundation family. I know we have some current clients here, so I'll keep this part of it very short for you folks, but just want you to know that, whether you're a current client of ours or whether you're not, we have multiple products here that are geared towards helping nothing but contractors like yourself, all the way from where we started as a full job cost accounting ERP system there, Foundation Software, to project management, HQ suite, where, we have safety tracking, just managing your projects in the field. Again, a lot of you familiar with Payroll4Construction. That is a standalone payroll service where, without owning any one of these certain products, these all can work independently along with other softwares. Things that if anyone is interested after this, they can reach out to me directly. I'd be happy to answer questions or point you in the right direction. And then even before a job starts, the estimating piece, McCormick for electrical, mechanical, and plumbing contractors. So if you're doing any of this stuff in Excel, we have dedicated products for this stuff. Even for our roofers, fireproofers, concrete, interior, exterior finishes. Edge is a nice estimating software for that as well. And then WorkMax, which is a mobile time collection system. Getting time cards from the field can be a real pain these days. Making sure your employees are, where they say they are when they were supposed to be there. Adam here in a second is going to talk to you all about, kind of reducing some of those benefit costs. But WorkMax and a lot of these solutions are great time savers within the office itself, where, time collection, making sure employees are where, again, they're supposed to be, and really just different products that can really help streamline other areas of your business. So I know you're all here to learn more. So enough with the sales portion of this. But again, if anybody has any questions on these products, you can always reach out here to me, Jim Welsh, and we'll take very good care of you. So again, thank you all for your time. I'll be here at the end to answer any questions on any of our products. But without further ado, I'm going to hand this over to Adam. Adam, thank you very much for your time, sir.
Thanks, Jim. Thank you for giving us this opportunity to speak to your customer base. Really appreciate it. Quick commercial. So my name is Adam Bonsky. I'm the CEO of the ABC Insurance Trust. The ABC Insurance Trust has been around since 1957, believe it or not. The Trust's main point and purpose is to act as a resource for members of the association of the ABC when it comes to their needs around employee benefits. And employee benefits is a broad spectrum. There is major medical and ancillary and individual accounts, even retirement. So at the Trust, we help members with all those different types of benefits. And we do our best to create programs that are unique to construction, that solve the unique pain points that contractors have, including those that work on government contracts and need help with Davis-Bacon or state prevailing wage rules. So with that brief commercial, let's dive in. We're going to talk about a subject that is frustrating for many. It is a subject that also feels like it's out of control. like there's no way for us to impact this ever-rising cost of healthcare. We're going to focus mostly on healthcare today. We've mentioned benefits up front, but we're going to focus most of the time on healthcare. So here's the agenda. We're going to talk about the state of healthcare today and give you a number of statistics to kind of help you see what's going on out there. Let's just say you're going to love this section, in quotation marks. If you're not already frustrated with your healthcare plan or the costs associated with it, then I may make you more so. But I will provide some ways to gain more control and bring down those costs. So stay tuned. Secondly, we're going to talk about self-funded plans. Believe it or not, over 60% of the construction workforce is they are a participant in a self-funded, or what I'll call later a partially self-funded health plan. So I think for many of you on this call, this is something for you to strongly consider, that you should start considering whether it's time to start moving your plan in the direction of self-funding. And I'll explain more why later. The two biggest cost areas in any health plan are the hospital and facility costs that your plan will bear, so the medical side of things, not including primary care and specialists. And the other big one is pharmacy costs. The two of those together, hospitals and pharmacies, typically make up 90% of the claims cost in any healthcare plan out there around the country. And only 10% typically of your workforce is driving that 90% of claims. And so the good news in that is this is addressable. If you can target or laser in on those few employees that are driving most of the cost, and the hospitals they're using and the pharmaceuticals they're using and how they're procuring them, you can go a long ways to driving your costs down. We'll talk more about that. Next on the agenda is to talk about member advocacy and experience. So it's not just important to look at the cost, but also to make sure the care is there. If people are putting off care because they can't afford it and they're getting sicker, then they're going to become part of that 90% of your claims costs. So making sure your employees have good advocates in your plan to help them get the care they need and guide them through it is just as important as focusing on the cost of the care itself. And then we'll wrap it up and talk about some notable trends in employee benefits, particularly in healthcare. And if there's time, we'll talk about some things going on with the government contracting side of things. Now, given the time we have allotted for the presentation, I can't get too far into the weeds on any one subject. So what I'd like you to look at today is, how I would like you to look at it is a set of ideas, a checklist, if you will, of things that you can consider for your health plan or plans going forward. And if more detail is wanted down the road, then we can set up subsequent webinars, or you can reach out to me directly and I'll get you more information. Okay, so next slide. We're going to dive into this subject that I said is probably going to frustrate you a little bit. You're maybe a little angry, a little frustrated with the lack of transparency, the lack of control that you have with your healthcare plan. But at least through this presentation, I hope to have you see a little more, or a sense of what's causing these healthcare costs to continue to go up. And secondly, what you can do to start getting more control and managing those costs and bringing them down. Part of what has made healthcare so expensive over the years is that we've focused on making it easy. And easy is great, but when you make things so easy that people stop paying attention to what things cost, then the costs start to get out of control. And so some of the changes I'm going to suggest are going to require more work from you or from your workforce to get more involved in their healthcare, what it costs, and the type of care, quality care that they're getting. So behaviors are going to have to change for costs to go down and for care to improve. So we'll talk more about that. But I want you to remember two specific things: transparency and control. Those are the two things you want more of with your health plan. A deeper look into what's actually going on and more levers that you can pull to control the plan and how it works for your employees. So let's dive into the state of the healthcare system these days. In the last 24 years, I've got new data here in front of me. In the last 24 years, the average annual salary has gone from $32,154 up to, in 2024, $59,436. So some growth, but over 24 years, not that substantial. Because employer health plans and the cost being borne by employees keeps going up, employers are offering coverage less often. So since 2000, the number of employers offering a health plan has gone from 69% down to 53%. That's a troubling number, even with the passing of the Affordable Care Act back in 2010. This is the stunning number right here. The average cost of family coverage since 2000 has gone from $6,400 up to $25,500 in 2024. So the cost that employers and employees have to bear just keeps going up. And a lot of you are probably wondering, how can we address that? The next slide. I'm not sure if any of you have heard of the RAND Corporation, but they're a nonprofit, nonpartisan research organization who focuses on public policy issues. And so they do a lot of work to gather data to help both at the federal level and the state level, agencies understand what's going on in a particular segment of the economy. And so we're going to talk about some of their findings around healthcare. So if we could bring the next several bullets down, I'll take you through some of their findings. And a lot of this is not going to be a surprise to you. So 1/3 of Americans have to take out a loan to pay for medical expenses. 38% of adults enrolled in a high deductible health plan are skipping or foregoing recommended medical care because it's too expensive. So in some cases, the push towards consumer-driven plans has backfired in the sense that employees are putting off care because we put so much cost on them. So it's not just about giving them greater visibility into what things cost. It's also making sure that they can find ways to get affordable care. And we'll talk more about ways to do that, of course. 52% of insured Americans feel stressed out about their medical bills. It's also affecting their mental health. We're seeing a huge uptick in mental health provider utilization. Since 2000, deductibles have gone up 473% and premiums have gone up 355%. While at the same time, wages have gone up 178 and inflation's gone up 167. So huge disparity here between what people are making and what their health plans are costing, both in out-of-pocket and in the premium. We'll talk a lot more about this last bullet, that employers are paying, on average, 254% more than what Medicare pays for the same services. And some states are quite a bit higher than that. So let's flip to the next slide. This just shows a picture of how much disparity there is now between what employees' wages are and what the premiums and deductibles or out-of-pockets are for them. So it's 4 times faster that it's growing in the last 24 years, and we're not seeing it slow down. I'll share some information with you in a minute from some of the major carriers that suggest that 2025 is going to be another year of increases. On the next slide, this further explains this percentage over Medicare that employer health plans are paying for the same care. So the average across the country is 254% on top of what Medicare costs. And as you can see, in several other states, that percentage is quite a bit higher than 254%. So this is what your plan, your health plan is paying. And in many cases, even if you're on an individual plan, what your individual plan is paying on top of what Medicare pays for the same services. On the next slide, you can see a breakdown by every state and how much over Medicare, on average, health plans are paying over and above what Medicare pays for the same care. So as you can see, it's not a great picture, and we should be asking the question as to why, particularly hospitals, are charging the private sector, if you will, or not folks that are on commercial health plans so much more for the same care. Next slide. There's also a big problem on the pharmaceutical or drug side of the equation. There's some good news there, but there's embedded bad news. So 60 to 65% of the drug costs in your plans are driven just by 7 to 10% of the prescriptions. Most of the prescriptions, as we all know, are a few dollars. They're not very expensive. But there are medicines now that are $500, $1,000, $10,000 a month that are driving a lot of additional cost into health plans around the country. The top 100 drugs in the US, the revenue exceeds $205 billion. That's in 2019. So just imagine what the number is today here in 2025. We can get that if you're interested. There's also a big problem with PBMs, or what are called pharmacy benefit managers. The Trump administration has made it clear that they're going to go, if you will, go after PBMs and the apparent markups that they're driving over and above what the drugs cost. The PBM industry is a $557 billion vertical or industry, and it's just kind of run amok. You're starting to see states like Arkansas last year in September put out some rulemaking that it's going to require all the health plans in that state who are utilizing PBMs, which is all or most of them, that they expose all of their fees, and so that PBMs can really start to be put under a microscope. But their point and purpose is to distribute medications at a lower cost, and this clearly doesn't seem to be happening. So there'll be a lot of, I think you'll see action in the coming years on driving down PBM costs in health plans. Next slide. So the good thing is there's a lot of innovation happening in the pharmaceutical industry. So there are drugs now that are really beginning to cure cancer, and gene therapies that are taking care of genetic disorders that really had no solution in the past. So there's good things happening, but that innovation is extremely expensive. And the drug companies are passing across the cost of that research and design to the consumer. And so good news is innovation is happening. The bad news is that it's really expensive. Now, in theory, with this increased innovation on medications, we should see some reduction in hospital care because the medications are helping people stay out of the hospital. So that's left to be seen. But what the net effect is that you're going to see in your plans, the claims attributable to pharmaceuticals or to medications is going to keep going up. Today, it sits around a 3-to-1 ratio between medical spend and pharmacy. But in the next couple of years, we're seeing that's going to continue to increase, where you might even see in the next 5 to 10 years a 50-50 split between medical costs and pharmaceutical costs in your health plans. Now, here's what I'll leave you with as far as pharmaceuticals are concerned. A drug is a drug, right? All providers are not created equal. There are some great doctors and some not so great doctors. There are doctors that are high quality that charge low prices and low quality that charge high prices. There's quite a bit of disparity in provider quality and cost. With pharmaceuticals, a drug is a drug, right? So you should always in your health plans be looking for the lowest cost way to obtain that medication for your workforce, because there's no difference from one person to another, if you will. All right, a couple of quick notes, and then we're going to talk about cost containment best practices around self-funded plans. Here's what we're hearing some of the major healthcare carriers, CFOs saying. United Healthcare, loss ratio spiked in 2024 to 88% from 83% in mid-2023. Cigna, surge in specialty RX and cancer stop loss claims in late 24. So they're surging in late 24. Expect significant stop loss price increases in 25 and 26. So I've got a few other carriers here that have quotes in the news recently. They're all saying that they're seeing more claims and their costs going up. And I think you can all be certain they're going to pass that along to the consumer. So this conversation about how to bring down healthcare costs is so important right now. So with the next slide, we can start diving into some of the ways that you can start to contain some of these costs. And so this is where I would suggest, hey, these are just ideas. Jot down some of these ideas, and we'll dive in a little bit here, but can always follow up separately if it helps you out. So first and foremost, on the next slide, let's talk about an unlocking maneuver. On the left side, you see more of the big health insurance type solution. And on the right side, what you're looking at is more of a self-funded, or what I'll call partially self-funded scenario. On the left side, everything's locked up in a box. So the carrier holds all the cards, they make all the decisions. There's no opportunity for you to manage or influence claims. Oftentimes you don't get very much of any information about claims, or if you get claims information, it's only on the top 10 largest claimants you have in your plan. A lot of times you don't even get information about the RX spend. So we say here, house money, house rules, right? So they control everything. They control the pooling points. They control who your plan is pooled with their other clients, right? And so they're always determining what the plan is, how it's structured, how the risk is set up. You have very little control. On the right side is what it would look like if you did a self-funded plan or a partially self-funded plan. So this breaks it down into 3 key areas. The biggest cost area is always your claims, right? So it's your medical and RX claims. The second piece is your stop loss insurance, which we'll talk more about in just a minute. And then your administration. So the bottom 2 buckets are what I call fixed cost. They're not variable. They're set in stone when you sign up for your health plan at the effective date. The claims, the medical and RX claims, are the ones that are variable costs. An actuary will help you try to project what those costs will be, but they're going to be variable throughout the year. So a lot of people feel like self-funded plans seem scary because there's a sense of this uncapped risk. If I self-fund my plan, that I could have this unlimited exposure. And while if you purely self-funded, which a lot of really big companies do with thousands of employees, yeah, you would be responsible for all of the claims costs. But smaller employers that don't have thousands of employees, partially self-fund is what I like to call it. And so you can cap your risk, much like you do with a fully insured policy. You can set the limits up to which you'll spend dollars on healthcare, and the point above which the insurance company covers those claims. So on the next slide, we'll talk about the 2 basic types of insurance you see in a partially self-funded plan. One is the specific coverage, and one is the aggregate stop-loss coverage. Let's talk about both of them. The specific stop-loss coverage provides a limit to what you will pay on any one claimant's claims costs. So you might pick a specific deductible of $50,000 or $25,000. What that means is your company will pay the claims for an individual up to that $25,000 or $50,000, and the stop loss insurance will pay for all claims costs above that number. So a contractor might say to me, well, that sounds great, but what if I have a bad year and I have a lot of claimants? Well, that's where aggregate stop loss coverage comes in. That's your protection across all claimants, all claims across your plan. So you cap it at the individual level, and you can cap it at the total plan level as well. Now, as companies get bigger, they may have just specific stop loss coverage, but will stop aggregate stop loss coverage. It's very rare, believe it or not, that aggregate stop loss coverage, especially for large companies, kicks in. But if you're a smaller company or coming out of a fully insured plan, then typically you're going to want to have specific and aggregate stop loss coverage so that you can know the totality of your risk for any given plan year. So hopefully that made sense. So let's move on to the medical cost containment side of things. I'm going to show you on the next slide another frustrating set of data. So this map shows you what hospitals mark up their care, the cost of their care, over their cost. So I'm in Texas, and we're a red state in two ways. One is on this map, and it's not a good story. Hospitals, on average in Texas, mark up their care 986% over their cost. Look at Florida. Florida's over 1,000% over cost. So if you look at that charge master or any of the services they provide in a hospital, they are charging a significant amount over their cost all over the country. And how do we know this? Any hospital that takes $1 of Medicare has to report all of their charge master fees and costs to the federal government, to the CMS. So they're fully exposed, they're fully audited now. So we know what they're charging over cost. And as I pointed out earlier, Medicare is quite a bit lower than the numbers you're seeing now. What Medicare pays for the same services is quite a bit lower. So we're going to talk about the first cost containment tool that you can consider. On the next slide, it's something called reference-based pricing. And I will say reference-based pricing is not for everyone. There are a lot of challenges with rolling it out, but it can be a massive cost savings tool. So on the left side of this diagram here, you're looking at what it looks like, if you will, when you are in a fully insured position with United Healthcare or Cigna or Aetna. They have a network set up with as many providers typically in hospitals as they can find in a given area. And there's a charge master fee that the hospital says, this is what we charge for the service. The network, through, again, United Healthcare or Cigna or Aetna, they negotiate down from that charge master price. Usually it's a 50% discount off of that charge master price. Sometimes it's more, sometimes it's less, but generally speaking, most of your health plans are going to see a 50% reduction off the charge master price. So if the charge master price is $5,000 for a particular service, and the network gets you $2,500, then that's what your plan or your employee plus your plan will pay for that service. Reference-based pricing doesn't start from the top. It starts from the bottom. It says, what does that same service cost the hospital to provide? Or what does that hospital accept from Medicare for that same service? And it adds profit. So a lot of reference-based pricing providers or TPAs will pay the claim at either the cost of the care plus 12% or Medicare plus 20%, whichever is greater. We see that's a very common way of paying claims on a reference-based pricing arrangement. So in this scenario, based on what I just described, a reference-based pricing plan would pay $336 for the same service that someone in a network-based plan paid $2,500 for. So there's a massive disparity. And extrapolate this notion over the top of claims that cost $50,000 or $100,000 in your plan. There's a massive drop-off in cost when you start from the bottom using a reference point of either Medicare or cost and adding a fair margin. A self-funded plan, any health plan, is an ERISA plan. And for those of you familiar with ERISA, the cost of an ERISA plan, any cost, any fees associated with an ERISA plan have to be reasonable. And so this is why hospitals can't win this battle. If you're in a self-funded plan or an ERISA health plan, then legally speaking, what you pay for care under that plan has to be reasonable in nature. And so reasonable is not 500% over cost or 700% over cost. So that's why and how these plans can work. Let's look at the next slide and you can see a specific MRI example. So these are 3 unnamed hospitals in Philadelphia who are offering MRI procedures. It's a standard image. There's only, I think, 3 machines that take these pictures. So in the first column, you're seeing what the average billed price by the hospital to the insurance is. So it ranges from $2,500 to almost $5,000 for MRI pictures. The average cost of that MRI varies from $100 to $117 in these 3 hospitals in Philadelphia. And I can say this is very indicative of what you will see around the country. Medicare pays $159, $125, and $177 for those MRIs at those hospitals. So even at a 50% discount that you're paying through your PPO plan or through the network in your PPO plan, you're still paying $1,200 on up to $2,300 for that MRI. In an RBP plan where you're working off of cost or working off of Medicare, you're only going to pay, you or your employee, depending on the deductible or out of pocket, of course, are going to pay $191 up to $212. So what I like to do is think about an employee who's making $75,000 a year and doesn't have $2,300 to pay a hospital to get an MRI. But he or she does have $212 to get that service, to get that treatment. And so that's what we need to see happen. We need to see people not putting off care. They need to be getting care and getting images taken early so that they can resolve these things or put care treatment plans in place to get better. But when it costs so much out of their own pocket, they're gonna put it off, right? Or they're gonna put themselves in a financial pickle to be able to afford it. So a couple of quick coaching items on reference-based pricing, because like I said, it's not for everybody. There's no network when it comes, generally speaking, with pure RBP or pure reference-based pricing. So you may want to consider putting in what's called a physicians network so that your employees can access primary care doctors and specialists through a network book, right? So in some cases, an employee in a pure reference-based pricing plan may go to a doctor and they say they don't recognize that insurance, right? And your employees might have trouble accessing care at the beginning. It gets resolved on the back end, but sometimes they have an issue at the doctor's office. So adding a physician's network to a reference-based pricing service, if you will, or a plan provision can really help your employees in terms of just finding access to those primary care and specialist providers. Also, consider offering a dual option. This means offering, let's say, a Cigna option that has a network and a reference-based pricing option for your employees, and let them choose with their pocketbook, if you will. As you might imagine, if you put 2 plans like that side by side, the Cigna plan is going to be more expensive. But give your employees the choice. Maybe they're not ready for reference-based pricing or to do that extra work they might need to do to find their own doctors and be ready to have some balanced bills maybe show up on their doorstep that they will not be responsible for, by the way. So consider offering a dual option where the employees can choose between reference-based pricing or a Cigna or United option. Also, all reference-based pricing TPAs and vendors are not created equal. So you want to make sure you're finding one that has a good reputation, has great references, and can do a good job for you. One last note on this is when you're looking at a health plan, especially on the self-funded side, and you have data about your hospital claims and you have data about your RX claims, and you're looking to change to a different provider, have them do a reprice for you. Have them show you what the hospital claims, how those would be adjudicated under their plan, under their services. What would the medications cost under their plan and through their PBM? So that you can get a real sense of what the claims cost for hospital and pharmacy might cost going forward. Don't go into it blind, if you will, and make sure that they actually have ways and means to bring down those costs for you if you're going to make a change. So remember that word reprice, and I'll show you an example of a RX reprice here in a couple of slides. Last but not least, if you're going to offer reference-based pricing, you have to educate. It's not just an enrollment meeting either. It's got to be an ongoing education program to make sure your employees understand how reference-based pricing works. Okay, next slide. Sorry, there was a lot on that one. High performance networks. So what insurers have done over the years is tried to create a massive amount of access for their insureds by adding as many doctors and hospitals and facilities as they can to their network. They've made them massive, right? And so many of you have seen the pages and pages and pages of providers and hospitals that are in United Healthcare's network or Cigna's network, and they're proud of that. They're proud of the fact that they've got all these doctors. And so while that access is great, it's very difficult for your employees to determine who the high quality, low cost providers are in there. It's just difficult to discern. It's getting better. There's more data out there. There's more tools out there to help employees figure out who those providers are. But a lot of them don't use them or don't know how to use them, or their employers aren't helping them with that. So there's a lot of people choosing low quality, high cost providers unknowingly and driving more cost to themselves and to your plan. So what a high performance network is one that says, we're not going to let just any hospital or provider in here. We're going to focus on only offering through this network those providers that are high quality, low cost, great outcomes at a reasonable price. And so if you offer a high performance network through your plan, what you want to do is steer your employees to those providers in that network. And you can do so by changing their out-of-pocket costs when they do so. So for example, you see a lot of plans who will say, if you use providers in our high-performance network, we will either eliminate or reduce your deductible. So that these folks are getting to higher quality, low-cost providers that drives down their costs and the cost to your plan. So there are a handful of these high-performance network providers out there. Ask the question of the people who support you in your plan to see if they could be factored into or built into the plan you offer now. Next slide. Another idea for you is what we'll call bundled cash pay platforms. These are also sometimes referred to as bundled surgery centers. So this is going to sound like I'm making light of it, but it's kind of like a Happy Meal, right? So oftentimes when people get surgeries, let's say a hip replacement, they get a million bills afterwards. You know, they're getting bills from the surgeon and the anesthesiologist and the facility and the folks that create the hardware for the hip joint and all the supplies that are used in the surgery room, so on and so forth. And you're getting all these different bills and you can't make heads or tails of it. So a bundled cash pay solution is just that. I look at the menu and I pick a hip replacement and everything's included for one all-inclusive price. And what's nice about these bundled surgery centers is because they do a lot of volume at a reasonable price, they're better at the procedure. They have more at-bats, if you will, in baseball terms. In some cases, certain hospitals will only do a couple of hip replacements all year and they'll charge you a ton for it. So bundled surgery centers are efficient, they're clean. Hospitals have a lot of problems with so many people coming in and out that there's more complications that come from infection than you would in a bundled surgery center. And most importantly, they're a lot lower cost. So you can see as much as $30,000, $40,000 difference in a knee replacement or a hip replacement. And this makes a huge difference, not only to your employee, but to your plan. And again, if your employees use a service like this, then waive their deductible. Incentivize them to go there because your plan will be saving $20,000, $30,000. So this is just another idea. You'll be able to look these up as bundled cash pay platforms or bundled surgery centers, and they're all over the country. Next slide. So this is one of my personal favorites, and what I'll refer to this broadly as is direct primary care. And so direct primary care providers are doctors who are so frustrated with the insurance system that they've given up on it. They've left it entirely. They've said, I'm tired of seeing 19 patients a day for 10 minutes at a time. I'm tired of employing 10 people in the back room to handle all of this billing and following up nonstop with all these different carriers to get paid 90 days or 6 months later, they're done with it. They want to provide great care. When an employee comes in or a member comes in, they want to see them for an hour and cover all their risk factors. So they've jettisoned the insurance model and they've adopted a membership model where you pay a set amount per month to belong to their practice. This has been a trend for the last almost 2 decades now, maybe even a little longer, where primary care doctors are getting fed up and they're leaving the insurance system and starting their own practice on a membership-based model. Now, some people say, oh, that's like concierge. And I'll say, maybe. A lot of concierge doctors are taking the insurance for your visit as well as charging you a monthly fee to belong to their practice. So direct primary care is completely outside of insurance. And there's also a virtual primary care version you can subscribe to as well. So it really depends on whether you want to see a doctor face-to-face and virtually or only virtually. But the nice part is it's your doctor. You're not seeing a different person every time you go to the doctor's office. And they manage your care. They refer you out to specialists. They're your coach. You know, I'm a member of a direct primary care practice, and I have my doctor on text. I have them through a mobile app. I can email them, text them, chat them day and night for me and for my children. So consider this not only for yourselves as a way to improve your health, but also consider it as something that you can look to offer in the future for your employees. The actuaries are still getting their heads around this, but direct primary care has a massive impact on the claims cost in your plan. It's attacking that 90% of your claims cost that comes from hospital care and pharmaceuticals, because it's helping to get people healthier and managing their healthcare process, if you will, what they eat, how they exercise, the medications they need to take day in and out, and making sure they're staying consistent with those. As opposed to most of us experience the whole 20 minutes in the lobby, 10 minutes with a nurse or PA filling out a bunch of forms with their back to us. The doctor comes in for 9 minutes, graces us with their presence, fills out a couple of prescriptions and leaves. I mean, that's how a lot of primary care feels these days. And so direct primary care, again, I told you it was one of my favorites. It's such a great innovation and it's something to look into. Before I leave medical cost containment, one last item. There's something called an organ transplant rider that you can have added to your health plan. Organ transplants are massively expensive. You know, they can exceed $1 million depending on how bad the situation is. And so an organ transplant rider for a relatively low amount per month can completely remove that organ transplant risk from your health plan. And so if you don't have one on your self-funded plan, for example, now inquire about it, because it's a great way to take off and remove a tremendous amount of potential risk for your plan. Okay, next up, and I know we're running short on time, so I'm going to keep moving. I'm going to talk about cost containment on the pharmacy side. Next slide there. This slide breaks down kind of in terms of the amount of savings that you can generate by using these different programs. And so patient assistance programs can save you the most money, and international pharmacy sourcing is a close second to that. I won't spend a lot of time on mail order and copay assistance programs. I'm going to assume a lot of you know what those are already, how you can save money by having medications shipped to your employees' homes. There are copay cards or copay assistance programs that you can get to reduce the cost of medications for at least several fills, sometimes multiple fills. But those are pennies compared to the thousands you can save on these first two programs. And so a patient assistance program comes into play where pharmaceutical companies are required to set aside certain amounts of money for not low income, but I'll say lower income individuals. And that money is intended to help pay, if not all, most of the cost of the medication for that individual. So when we look at the census for a lot of our contractor employers, a lot of their employees will qualify for a patient assistance program for assistance directly from the manufacturer. And so to the extent you have an employee on a drug that costs thousands of dollars a month, you and they can't afford not to look into whether they qualify. And as you might imagine, the tricky part here is filling out the paperwork that's required to obtain that money from the pharmaceutical company. So if you're working with a strong third-party administrator or a carrier solution in some cases that can offer patient assistance programs, inquire about it, because you may have employees that can get that medication for free or for a lot less cost, and that saves them money and you money. International pharmacies are another thing to look at. On average, the United States pays somewhere around 8 times more for the same medications that other countries pay for the same medication. So Canada, United Kingdom, India, Ireland, all of these countries are just examples of countries who can source or can deliver medications to the United States into health plans at a much lower cost. And what's fascinating is a lot of the medications that we're taking here in the United States are manufactured in those countries. So bottom line is there are many ways to get medications to your employees at a lower cost. This is a function of working with the right pharmacy benefit manager or RX cost containment solutions that are out there that can help you and your employees qualify for patient assistance programs, source medications internationally where they can, and of course, as always, take advantage of mail order and copay assistance programs. So on the next slide is just a quick example of how much difference in costs there can be with sourcing medications internationally. So look at the Eliquis, Trulicity, and Otezla here. We'll start with the most expensive one, $4,300, and this is a month for a medication. You can source that same medication internationally for $1,200. Massive savings, 70% differential. So RX Valet, you see on the slide here, is just one of the many cost containment vendors out there that help to bring down the cost of medications. And one of the ways they do that is through international sourcing, but also through helping employees complete patient assistance programs paperwork. So international sourcing creates huge savings. And on the far right, why charge your employee anything for that drug if they get it through international sourcing? You're saving thousands of dollars on that medication for your plan. Don't charge the employee a copay. On the next slide, you can see what the impact is of a patient assistance program. It costs $40 for the employer to pay typically your cost containment vendor to fill out the paperwork to get your employee who's qualified the funds directly from the manufacturer to pay for that medication. And that's it. If they qualify, then you get the Skyrizi or the Humulin or the Ozempic at no cost, other than the amount you pay for the paperwork. So again, PAPs and international sourcing are going to be two of the biggest ways that you can drive down that huge expense you have on pharmaceutical spend in your health plans. As I said earlier, ask for a reprice. On the next slide, you'll see an example of a reprice we did recently for a contractor in Tennessee. They were with Blue Cross of Blue Shield of Tennessee. And we looked at all the drugs that they were taking and how much they were paying for them through Blue Cross and what they would pay for those same medications through a vendor like RX Valet. And I'm not getting paid to talk about RX Valet. There's a lot of companies out there that can do what I'm talking about here, but look at the difference. This is a company with about 200 employees. We ran the reprice for them, and look at the amount of savings on RX they can experience in the year following coming off of a Blue Cross plan. As many of us know, many of the pharmacy benefit managers out there are owned by the insurance carriers. United Healthcare owns Optum, right? Aetna and CVS are together, right? So they're driving the cost. There are ways to get around it. So moving on, since we have so little time left, we're going to talk about member advocacy very quickly. Again, it's important that your employees have someone to help guide them through their healthcare journey. And that's not just the care they receive, but what they pay for that care. One of the things that people don't realize is that hospitals Just like, next slide, by the way, hospitals, just like I described earlier with pharmaceutical companies, are required to set aside money for lower income individuals to help with their out-of-pocket costs. So there's an IRS code section 501R. You can see it there on the far left box that requires hospitals to set aside funds for lower income individuals to help with their deductible. So on the next slide, I give you a list of hospitals in Florida, just as an example, and how much they, up to the salary, if you will, they will provide assistance. So you can see for some of these hospitals, your employees that even make up to $100,000 are eligible for partial relief. If they're making $50,000 to $62,000 a year, they're potentially eligible for free care at that hospital, covering whatever their out-of-pocket is through their health plan. Across the country, the average income threshold for free care for a household of 3 is $53,000 a year. So you undoubtedly will have employees that fall into this bucket, and it's a matter of knowing how to fill out the paperwork and pursue the hospital for that money for your employee, and there are companies out there that can help you do that. Next slide. Maternity advocacy. This is one that oftentimes is sort of undervalued, if you will. Many health plans end up getting large renewal increases because one of their members' babies ended up in a NICU. And NICUs can be days or weeks of hospital costs. It can go up into the hundreds of thousands, even more than $1 million. And here's the crazy thing is most NICU experiences are avoidable. I know that may sound crazy, but most of them are avoidable. And so if you have a maternity advocacy program in your health plan, promote it. If you don't, add one, and make sure that your employees or their spouses who are expecting sign up for the program and get the advice early on and guidance from this type of member advocacy service so that they take care of themselves properly through that pregnancy and avoid NICUs. They don't want them and your plan doesn't want them. So like I said, this one often gets overlooked. Next slide. The Samaritan Fund. Now this is an interesting program and you can look it up after we finish this call today. But in some cases, a plan will have a really hard case where it's a transplant or it's a serious cancer, maybe even a terminal cancer that may go for a year or two, but it's a really expensive case on your plan and it's draining your plan of costs. So what the Samaritan Fund does, it's a nonprofit, is it will take the employee off of your health plan and put them on their own individual plan that's more suited for the type of care that they need. And they'll pay for their premiums, they'll pay for their out-of-pocket costs, and provide nursing care and advocates to guide them through their healthcare situation. So in a lot of cases, it feels helpless. Like I've got this individual who I want to make sure gets all the care they need, but they are costing us hundreds of thousands of dollars or maybe even millions of dollars. How do I help this person, but also help the rest of my workforce? The Samaritan Fund can be a solution for that. And we provided some instructions here on how it works. Again, if you need any more information on it, let me know. All right, we're coming into the home stretch. A couple of notable trends in employee benefits. On the next slide, we're seeing more medical stop-loss captives. Many of you have seen captives utilized on the property and casualty side of your business, but there are more medical or healthcare captives emerging over the last 5 to 10 years. And this is where, for those of you who aren't familiar, where employers can band together with other like-minded employers to form a special purpose legal entity or insurance entity and can take some of the risk taking away from the insurance carrier and share it amongst themselves. Insurance carriers charge a lot of fees, right? So they're charging you in their premium filing fees and admin fees and marketing fees, and they got to pay their salespeople and all of that. So to the extent you can take some of that risk yourself with other like-minded employers, you're going to pay less in insurance costs. And you cap your risk because you know what the captive layer is going to pay for, and then you know what the stop loss insurance is going to pay for on top of that. So on the next slide, I'll show you an example of what I mean there. As you see on the bottom, these are A through J. These are different employers who are part of a captive, and they can each choose a different specific deductible like we talked about earlier in the presentation. So if employer B has a $50,000 deductible and they belong to a captive with a $200,000 floating captive layer, then the employer pays the first $50,000 of claims for any one claimant. Anything from $50,000 up to $250,000 then is paid for out of the captive. And then your stop loss carrier pays any claims for that claimant over and above the $250,000. So that's how a captive layering process can work, where you're shifting some of the risks to the captive in that middle layer, sharing it with other employers, and bringing down the cost of your insurance. Meanwhile, you're building a program of cost containment tools that you and your fellow employers share to keep the cost down for all of you. So this is up and coming. There are more and more captives getting formed out there every day. At the ABC, we do have our own member-only captive called the Construction Healthcare Alliance. Sorry for the brief plug, but we've caught on to this trend and looking to benefit our members with the captive solution. All right, next slide. If you haven't heard of it, and it's a horrible acronym. The acronym is ICHRA, right? But it stands for Individual Coverage Health Reimbursement Arrangement. There are more employers every day deciding to opt for an ICHRA. I find them to be useful for many contractors because contractors have a couple of problems. They have very poor participation. They still have Affordable Care Act requirements for providing care. They have a disparate workforce, either around the country or in various parts of the state. They have differing needs between their office staff and what the workforce in the field needs for care. And so there's a lot of variability and difficulty in underwriting all that variability. And so an ICHRA, much like when pension plans started to convert to 401ks, an ICHRA is like a 401k from your traditional health plan. It creates a defined contribution solution for your employees and you to contribute to a pre-tax arrangement where they can then use those funds to buy their own individual policy. And the ICHRA providers that are out there provide services that help people pick those individual policies and help them interact and deal with service issues that they might experience or get the right care that they want to get through those individual policies. So this can be a great solution for contractors who are struggling to provide an affordable option for their employees. You can divide ICHRA up into 11 different classes. I won't go through all of them on the call today, but if you Google ICHRA 11 classes, you'll easily see how many different ways you can break it up. But a simple way would be to offer your traditional health plan to your office staff and offer an ICHRA to your field workforce or for a particular location where you're having a hard time finding them a plan or an affordable plan. Okay, we are at time, and so I'm going to just quickly touch on the last two slides. For any of you who are bidding or performing on government contracts subject to the Davis-Bacon Act or a Davis-Bacon related act or a state prevailing wage rule, keep in mind there are fringe dollars built in here to pay for healthcare and other benefits. If you're bidding on any of the IRA projects that provide tax credits for the work you're performing, keep in mind if you get a tax credit, that also makes you have to comply with the Davis-Bacon Act. And so we're finding a lot of employers that are going, gosh, I had no idea I'm getting this tax credit. I haven't been complying with the Davis-Bacon Act. What do I do? So if you need help with that, let me know. Join ABC and we'll help you with the programs that we have that are suited to government contractors. Last up, again, if you're a government contractor, if you have a self-funded or partially self-funded health plan, it's always been the case, but DOL had some new rulemaking a year and a half or so ago where you have to get your self-funded or partially self-funded health plan approved by the Department of Labor, unless you're going to fund your plan. And fund means that you're going to put all of the fixed costs we talked about earlier and all of your costs for claims into the plan, and you're going to pay your claims and fixed costs out of it. So normally in a self-funded plan, you're paying your claims as you go out of your general assets. And if you're going to do it that way, then you're going to need approval from the Department of Labor. If you fund your plan and put all of the costs associated with it and projected claims costs into an account that's not one of your own owned accounts and pay claims from it, then you don't need a separate approval. So more detail to cover on that. If you're working on government contracts and you have a self-funded plan or partially self-funded plan, let me know. We can help you understand what's required to get your plan approved or how to fund your plan so you don't need to, frankly, put yourself in front of the Department of Labor. So I am sorry if at times the presentation sounded like the disclosure at the end of a pharmaceutical commercial. Hopefully you got some good ideas out of this. Please don't hesitate to email or call me. I'm not sure if my number is on the screen, but you can get it from the team at Foundation. Thank you, Jim, once again for giving me this opportunity to share some ideas today. I think you're going to wrap us up.
Yeah, thank you, Adam, so much for your time. We got a couple questions here. One is asking, will there be a copy of this? Absolutely, folks. We're not expecting you to retain all this, so everybody will get a link actually to the webinar, and then you can request if you want the PowerPoint, but we can get you whatever you need. You'll automatically get a link to this, so if you want to share with other coworkers as well. And then somebody's asking Adam that has probably been, kind of a one-on-one conversation, but do you have a list of requirements for kind of reducing the fringe or fringe benefit reduction? Like what, I'm assuming it's what can you reduce? And again, that's probably going to be state specific, but I'll let you speak on that.
Yeah, there's a lot of flexibility in the wage determination. Some wage determinations you'll see have a sort of like line by line, like you can spend this much on health and this much on dental, and I don't want to say you can ignore that, but you can ignore that. You have, let's say, $10 an hour, right, or $15 an hour to spend on benefits. And that $15 an hour is an employer contribution to the health plan or retirement plan or a dental plan, whatever the case may be. So it's the employer's decision on how to spend that $10 on the various different benefit programs. And so your health plan might cost you $3 to $5 an hour, depending on how rich your plan is. Then you might spend another $1 or $1.50 on your dental, vision, life insurance, right? And then whatever's left, let's say it's $3, your retirement plan can be your catch-all. That can be the plan that takes the rest of the fringe that you're required to pay. There's also the ability to say, I don't want to pay all 10 towards benefits. Maybe I want to put $3 of that $10 on the wage and put $7 towards benefits. So there's a lot of flexibility in the wage determination, particularly at the federal level. Some states, like New York, Illinois, California have some kind of stickier rules about what flexibility you have in terms of moving the pieces of the base and the fringe around. But a lot of states and at the federal level, it's very flexible. They just want to see that the total wage determination is paid in totality between wages and benefits. And clearly, the more you put on benefits, the less you're going to pay in FICA, FUTA, SUTA, workers' compensation, general liability, all those things that are your payroll burden. So I'm not sure if I answered the question, Jim, but I think bottom line is there's a lot of flexibility. And if you want to talk to me more about what flexibility you have, just shoot me an email.
Yeah, and they elaborated a little bit, Adam, but I think it'd be great for this person. I recognize the name, so they're a client of ours. So here on our end at Payroll4Construction Foundation, however you decide to slice that up. But really, more or less, I believe the term, Adam, is, and I've learned this from you over the years, is a bona fide plan. So taking it a step further, she was asking, like, how do we know if our 401k plan meets the requirements for that money to be able to go into there? You know what I mean? Which you and your team, you guys have plans there, and you, I'm sure, if we get you connected, could answer some questions on that.
Totally. There's a set of rules for what governs a bona fide health plan. We can talk about a few of them, but the plan needs to be communicated in writing. The fringe needs to be provided to a third party or trust. Third party certainly it can be your carrier. It can be your 401k provider. It doesn't have to be a trust, if you will. You've got to provide that fringe within 90 days. You have to communicate it in writing. I think I said earlier, it has to be provided to the people actually performing the work on the job. So there are bona fide benefit rules that makes the benefit okay in the eyes of the Department of Labor. One of the things that you want to keep in mind with 401k plans is annualization. So with most of your plans, major medical, dental, vision, life, disability, they're all subject to what's called annualization. Retirement plans don't have to be subject to annualization. They don't have to be contributed to for all hours worked, provided you structure the plan where it has an immediate vesting schedule and no more than, I think it's a 1 month wait. Ideally, you are letting people into that plan immediately and you're vesting them immediately in their fringe contribution. And then that gets you out of the annualization requirement for retirement plans at the federal level and in most states. Not every state has an exemption from annualization on retirement. So a lot of gobbledygook there. Hopefully it was somewhat helpful, but please have your client reach out and we can talk through what makes the benefit bona fide and how to structure your retirement plan.
Yep, you can just shoot me an email, this individual, and then I'll make the connection directly with Adam. So one other question here aimed towards me, how does our team help? Well, whoever you use for the benefits, we're going to help, set that up in our system. We'll be the tracking reporting mechanism. Some folks may know this, some may not. It's not with benefits enrollment yet, but we actually have a really nice HR platform now for onboarding where employees can see all this information. They can submit documentation to you to provide your provider with when there's life-changing circumstances such as having a child, getting married, where they need to change that plan. You would still handle that portion with your provider, but we do for both foundation and payroll for construction clients have a really nice new HR module that if anybody is interested, reach out to me on that, or if anybody just knows and remembers me and wants me to connect them with Adam and his team, feel free to do so. So thank you, Kara, on our end for putting this together, Adam for joining us and all the great information, and appreciate all of our clients that attended today. Hope you found it helpful, and we're here to help any way we can.
Thanks again, Jim.
Thank you. All right, everybody have a great day.